بسم الله الرحمن الرحيم. أنا دكتور عادل شبانة، مدرس القلب في طب عين شمس. محاضرة النهاردة عن الأكيوت روماتيك فيفر. ILOs of this lecture includes to understand the pathology and pathogenesis of acute rheumatic fever, to know how to diagnose acute rheumatic fever, to know the main points, the main issues of treatment of acute rheumatic fever, and to learn the duration and medications used for secondary preventions for rheumatic fever. Rheumatic fever, acute rheumatic fever is now rare in Western Europe and USA, but it is still endemic in Egypt and parts of Asia and Africa. The annual incidence may reach 100 per 100,000 per year in some countries. It usually affects children between 5 to 15 years old. Acute rheumatic fever is not a direct infection by the microbes. It's an immune-mediated delayed response to infection, which means we have an organism which is usually group A beta hemolytic streptococci, and not all the serotypes, only few of them. And these streptococci infect usually the tonsils or affect the body in general. And then, because there is some similarities between the antigens in these streptococci and the heart proteins, the antibodies which are produced against the pathogen will attack the heart and other organs and produce acute rheumatic fever. So we need an infection. After this infection, by nearly around 2 weeks or something, to give time for the antibodies to be formed, you will have the picture of rheumatic fever. And as I said, it's it's only group A beta hemolytic and not all the strains, only some of these strains. The pathology of acute rheumatic fever is the pathognomonic thing in the pathology is what is called Aschoff nodules. Aschoff nodules is only appearing in the heart. It is pathognomonic. It's multinucleated giant cells surrounded by macrophages and T lymphocytes, and usually seen later on. They are not in the acute attack, usually later on in the attack, and this is a picture of Aschoff nodules. However, when the valves, the heart valves are affected, they become thickened and vegetations can appear on the heart valves, and later on chronic infection, the valves become completely destroyed. So let's go back to the clinical picture. What will happen? Usually, the patient will start with pharyngitis or tonsillitis. The kid will start with pharyngitis or tonsillitis, and then after around a little period of around 2 weeks or something, until the antibodies are formed, he will start the attack of acute rheumatic fever. Typically, it will become a sudden onset of fever. Multiple tissues will be affected: joints, skin, subcutaneous tissue, heart, brain, and the most common feature in more than 3/4 of the cases is arthritis. So, as we can see here in the picture, beta hemolytic streptococci come in the pharynx, and then immune response will occur against these microbes, and the antibodies formed will attack mainly the heart with all the 3 layers of the heart: pericardium, myocardium, and endocardium, and this is called the pancarditis. So in order to diagnose rheumatic fever, we have what is called the modified Jones or revised Jones criteria. Jones criteria, there are 5 major diagnostic criteria and some minor diagnostic criteria, in addition to evidence of streptococcal infection. So we have 3 things. We have major criteria, minor criteria, and evidence of streptococcal infection. In order to diagnose definite rheumatic fever, we have to get either 2 major criteria or 1 major and 2 minor criteria, and in all cases we must find evidence of streptococcal infection. What are the major criteria? They are 5, very important to be known: carditis, arthritis, erythema marginatum, subcutaneous nodules, and chorea. So, carditis, heart; polyarthritis, joints; 2 skin lesions. One is called erythema marginatum, and the other one is called subcutaneous nodules; and Sydenham's chorea. These are the major criteria. If we find 2 of them, or we find 1 of them and 2 of the minor, plus evidence of infection, so you have definite rheumatic fever. Minor criteria include fever, ASR high, or C-reactive protein, prolonged PR interval, previous history of rheumatic fever, evidence of arthralgia without arthritis. So all these are minor criteria. And the evidence of streptococcal infection either by anti-streptomycin O titr or positive throat culture or any other things you can do to prove there is a streptococcal infection. Again, this is a picture cartoon showing Jones criteria: joint, polyarthritis, carditis, nodules, erythema marginatum, and Sydenham's chorea. The chorea is called Sydenham's chorea. These are the 5 major criteria. Important notes: chorea, as we'll talk about later on, can occur very late after the infection or after the immune attack. So sometimes if we have Sydenham's chorea, typical Sydenham's chorea, we can depend on it without evidence of infection. The evidence of infection, as I said, either a positive throat culture, which is not common because this occurs around 2-3 weeks after the infection, raised the titr, anti-streptomycin O titr either rising or exceeding 200 to 300, or evidence of scarlet fever before. So let's talk about the major criteria one by one. Arthritis, as I said, it's the most common manifestation in 75% of cases. It's typically acute, migratory, asymmetric polyarthritis involving the large joint, which means the patient, for example, will have swelling of the knee, let's say right knee joint, will become swollen, painful, tender for few days, and then it will resolve, and for example, the left ankle will start to become swollen, painful, and tender, and just like that. So it is called migratory or fleeting asymmetrical polyarthritis. And it should be arthritis, which means the joint is swollen, painful, red, and hot, and tender. Usually, if no treatment is given, it will be resolved, the whole issue will be resolved within 1 to 3 weeks, fleeting between different joints. But if you give salicylate, this is a very important, we can take it as therapeutic test. If the patient receives aspirin in good dose, within 24 hours, it will be resolved. Arthritis does not leave permanent damage. The next major criterion is pancarditis. Pan means the whole layers are affected. This occurs in half of the cases, and this is the most important issue because it causes destruction of the valves and causes morbidity and even mortality. It leaves permanent damage. The patient will complain of chest pain, shortness of breath, palpitations, heart failure, any symptoms, all symptoms of the heart can occur because it can be pericarditis with effusion or not, myocarditis with ash of nodules producing heart failure or heart block, and endocarditis, which means affecting the heart valves. So they can produce either regurgitant lesions or stenotic lesions. Usually in the acute phase, it is regurg. The valve will not close adequately, so a regurg will be formed. Sometimes because of the swelling of the leaflets, murmurs of stenosis can appear. For example, in the mitral valve, a murmur of stenosis can appear, and this is resolving by time, which is called the Carey-Coombs murmur. So Carey-Coombs murmur is a murmur of mitral stenosis, usually transient, occurs because of the swelling of the mitral valve in the acute rheumatic fever stage. The skin lesions which we talked about are erythema marginatum and subcutaneous nodules. Erythema marginatum occurs, they are very rare, sorry, they are very rare, but they are characteristic of rheumatic fever. They start as red macules, and then they fade in the center and they become enlarged. So later on, if you make, if you mark them by a pencil, and then after 1 or 2 days you check them again, you will find that they are increasing in size and fading and becoming pale in the center, but still red in the edge. Sometimes they coalesce together. This mainly occur in the trunk, in the proximal extremities, never occurring on the face. They don't leave any permanent damage. They don't need any treatment. They are not even. They don't cause any. Any problems. Subcutaneous nodules are the second skin lesions. Also occur around 5% of cases. They are small, firm, and painless, and they are usually on the extensor surfaces of bones or tendons. And usually they are confirmatory because they don't appear very early, and they disappear just later on without causing any problem. The last and the important issue is the Sydenham's chorea. Sydenham's chorea is a late manifestation. It can occur 3 to 6 months after the episode of acute rheumatic fever. Usually all other manifestations will be resolved and the chorea will just appear. It's very it's more in females. Usually there is some emotional lability. I mean, the girl or the boy can cry easily or become sad or happy easily. There is sudden, they are called sudden, aimless, irregular, involuntary, jerky movement. Sometimes they are said that they are semi-purposeful, which means the child, he will have this involuntary movement. For example, his hand will go up suddenly. So in order to make it like a purposeful movement, he will just maybe passing his hand on his hair. So it appears like he is really intending to do something. It can start as handwriting problems, difficulty in dressing himself, difficulty in feeding, walking, sometimes explosive speech, and usually disappear with sleep, but increase with stress and excitement. Sorry, I don't think the video is working here. There is some video, I got it from YouTube actually. It's showing a kid with Sydenham's chorea. You can just go and check it on the internet. And what's important is that this involuntary movement disappear with sleep and increase when the person is in a stressful condition, and they usually resolve spontaneously in 3 to 6 months. When we have a clinical picture suggestive of rheumatic fever, we have to do some investigations like laboratory investigations to check the evidence of systemic illness like ESR, C-reactive protein, and leukocytosis, and the evidence of proceeding streptococcal infection. Other investigations which can be needed, like chest X-ray to check for heart size, ECG, and echocardiography is important diagnostic issue. This is a chest X-ray of a patient during acute rheumatic fever showing cardiomegaly, and later on, after the condition is resolved, the heart become normal in size again. So what about the management? The first step is primary prevention, which is important. In order to treat, we have to treat adequately tonsillopharyngitis in order to prevent the occurrence of rheumatic fever. Management of acute attack will include 3 main steps. Number 1, to eliminate any residual streptococcal infection. We know that it is not an infectious issue, but maybe there is some remaining streptococcal infection in the tonsils or in the pharynx, so the patient has to receive either benzazine penicillin intramuscular injection, 1 injection, or oral penicillin for 10 days, or other medications if he is allergic to penicillin. Second step is bed rest and supportive therapy, which is guided by according to the clinical picture. And the third step is anti-inflammatory treatment, either aspirin or steroids. So the anti-inflammatory treatment is either aspirin. Aspirin is the main treatment for arthritis. It relieves the arthritis within 24 hours, which is very important therapeutic test. If it does not happen, we have to query our diagnosis. The dose of aspirin ranges between 60 milligram per kg per day to 100 milligram per kg per day in children and adults. And usually we continue on aspirin until the ESR becomes normalized or is getting down, and then we try to taper off. We have to take care of aspirin because these large doses for these weeks can cause some problems like tinnitus or deafness. The other treatment is corticosteroids. Nowadays we are not using corticosteroids that much, only in carditis if we have proof of carditis or if there is severe arthritis. So we will give prednisolone 1 to 2 milligram per kg per day in divided doses until ESR become normalized, and then during tapering off of steroids we have to add aspirin and continue the same aspirin regimen. The last important issue in our lecture is the secondary prevention. Secondary prevention means that a patient got one attack of acute rheumatic fever, then we have to prevent another attacks. So the patient will take benzazine penicillin 1.2 million units intramuscularly every month. This is the best treatment, which is better than oral penicillin or sulfonamides, but sulfonamides can be, erythromycin and sulfonamides can be used if there is allergy to penicillin. What is the aim of that? To prevent attacks of rheumatic fever causing more destruction of the valves and more problems. This does not prevent infective endocarditis, it's only against rheumatic fever. So for how long we have to give? Actually, there are many debates regarding this issue, but in a simple way, let's start from the easiest issue. A patient who developed proven rheumatic fever, but it did not show any evidence of carditis. So like he has arthritis, and labs are, I mean, we have a diagnosis of rheumatic fever, but the heart is not affected. In this case, we give this child antibiotic, the prophylaxis antibiotic, either for 5 years or until the age of 21, whichever is longer. So let's say if he is 15 years old, he will take until 21. But if he is 20 years old, he will take until 26. Okay, so we give a prophylaxis until the age of 21 or 5 years after the last attack, whichever is longer. If the patient developed rheumatic fever with carditis but no evidence of residual heart disease, I mean, we have approved that he had a carditis, but it resolved completely without any residual heart disease. So he will take prophylaxis into adulthood. Some people say 25 years or 40 years, or at least 10 years after his attack, whichever is longer. What about these guys who have rheumatic fever with carditis and leaving a permanent damage in the heart valves? In this case, we have either lifelong prophylaxis, especially in areas like our country where the rheumatic fever is endemic and socioeconomic status is not good, or to 40 years old, or at least 10 years after the last episode of rheumatic fever. That's all, and thank you very much for hearing my lecture.